Welcome to the heart.org. We're here at the Mayo Clinic with two of my colleagues from the heart failure study group, Dr. Margaret Redfield and Dr. Horng Chen. I'm Dr. Greene. I'm a nephrologist here at the Mayo Clinic, and I work closely with our heart failure group to optimize the care of patients with heart failure and kidney disease. Welcome, Dr. Chen, and welcome, Dr. Redfield.
Thanks, Eddie.
We're here to talk about the optimization of therapies to reduce volume overload in patients with acute decompensated heart failure who also have renal dysfunction. As you both know, it's a very common problem and an important problem that causes significant morbidity in our patients and prolongs hospital stays, causes multiple readmissions, and also increases the cost of heart failure. Sometimes estimates have suggested as high as 80% above normal hospitalization cost. So we're here to talk about that and mention one of the very new studies that have come out, the ROSE study, Renal Optimization Strategies and Evaluation for Treatment of Patients with Heart Failure. And I'd like you to tell us a little about that study and what did it test and its importance for the audience.
Great. Maybe I'll start, Maggie. So the ROSE-AHF study was done as part of the NHLBI Heart Failure Research Clinical Network study. It targets patients with acute heart failure and renal dysfunction, as we know that these patients are at risk for inadequate decongestion and worsening renal function during acute therapy. And as you have stated before, that is associated with worse outcomes. So it is a study that's designed to test two independent hypotheses. The first being low-dose dopamine, and the second being low-dose nesiritide. That if we add these medications to standardized diuretic therapy, we will enhance diuresis and natriuresis. And our target population are patients who are admitted for acute decompensated heart failure with renal dysfunction with an estimated GFR of between 15 to 60.
Okay. Those patients are usually very difficult to diurese, I suspect. Dr. Redfield, would you like to make any points about your experience with those patients?
Well, they are often very difficult to diurese, or if you start to diurese them, then the creatinine starts going up, and you're sort of in this conundrum. You don't want to worsen the kidneys, but you recognize that you really need to get the patient adequately decongested. So they are a tough population. And the thing about it is that quite frequently you can't adequately diurese them and the creatinine goes up, but it doesn't happen all the time. So this study really looked at the question, should we just prophylactically treat all these patients who are at increased risk, acute heart failure with renal dysfunction, prophylactically treat them with these agents, either dopamine or nesiritide, or should we wait and see who we can't decongest and who gets the worsening renal function and then just use these therapies in those situations. So this was a new kind of a concept, prophylactically targeting this group.
Okay. Well, let's talk about the study design and some of the findings. And I'll start with you, Dr. Chen. Talk about the use of dopamine in this patient cohort and how you designed the study to look at them.
Yeah, we know that low-dose dopamine, between 2 micrograms per kilogram per minute to 5 micrograms per kilogram per minute, has been previously shown in patients with chronic heart failure and reduced ejection fraction to selectively activate dopaminergic receptors in the kidneys and increase renal vasodilatation. However, and previous small studies have shown that when added to diuretic therapy in these patients with acute heart failure, it may enhance diuresis and preserve renal function. But a few caveats, those studies were usually single center, small studies, and the dose of dopamine use was varied between 2 mics to 5 mics. And also the diuretic dose was not standardized in those studies actually. So despite its potential to enhance diuresis and preserve renal function, it's never been well tested in patients with acute heart failure and renal dysfunction.
Sure.
And as Maggie said, in the ROSE-AHF study, we are sort of also testing a new concept that whether if we prophylactically use low-dose dopamine, whether we can result in enhanced diuresis and preserve renal function.
And I think, you know, one of the things to keep in mind is there is this concept that at low dose, dopamine may just, you know, activate the dopaminergic receptors. But there's a lot of people, based on clinical observations, who feel that really dopamine is mostly just acting like an inotrope, and that a low dose of dopamine is the same as a low dose of dobutamine. You know, so there was really a need for more information on this area.
Did the study specifically address that part of the pharmacokinetics of dopamine?
Not the pharmacokinetics, but I think it ended up addressing that question that we'll get to when we talk about the results.
Great. Yeah. The other part of the study used the drug nesiritide to look at whether you could induce an effective diuresis and sodium losses in the urine using that drug. Tell me about those results.
Right. I think one of the advantages of this trial is we tried to be very efficient and answer 2 questions in one study. So it kind of used a novel study design that Horng will probably tell you about. But the rationale for testing low-dose nesiritide is that nesiritide, we know from physiology, has effects on blood pressure and has effects on the kidney. And it was developed for treatment in acute heart failure really because of its vasodilating effects. And so there was given in relatively high doses to lower blood pressure, drop filling pressure, and improve symptoms. But when you do that, you quite frequently, about 20–25% of the time, induce hypotension. So that may negate any beneficial effects it might have on the kidney. So based on a lot of work by Horng and by John Burnett, this strategy instead used a very low dose of a nesiritide given without a bolus, so that we were trying not to drop the blood pressure, but have a renal dose nesiritide and see if that sort of a strategy could improve diuresis and protect the kidney. And we had some work by Horng to suggest that that may be possible. So that was the rationale for the nesiritide arm.
And what did the results really show? Can you tell us about that? Let's start with dopamine again here.
So maybe we enrolled a total of 600 patients. I'm sorry, 360 patients in the study. And as Maggie said, you know, we use a novel design to try to answer 2 questions, and also furthermore to minimize the number of patients that required a central line being placed. We actually first had an open randomization of these patients to the dopamine strategy or the nesiritide strategy. Then subsequently, within each strategy, they were then randomized in a blinded 2-to-1 fashion to study drug or placebo for 72 hours. So with that study design, we ended up with 119 patients in the low-dose nesiritide strategy, 122 patients in a low-dose dopamine strategy. And both these strategies were compared independently to the pooled placebo group, which was 119 patients. And also, to make a point that these patients were also on standardized diuretic therapy for 24 hours. Based on our dose study, we used 2.5 times their outpatient dose.
I see.
And I think that's a really important point, is that because this study was done in the Heart Failure Clinical Research Network, the trials are designed and performed by some of the leading heart failure centers. And in all our trials, the #1 thing is that if we're comparing anything to standard therapy, we make sure the standard therapy is state of the art. So if you're comparing something to look at its effect on diuresis, we want to make sure that you use the most effective diuretic. So everybody had to be on at least 2.5 times their outpatient diuretic dose for at least 24 hours, usually more. So I think that's a really important point to stress.
All the diuretics given intravenously?
Yes.
Oh, yes.
That's right. So what we found was that beginning with the dopamine group, you know, low-dose dopamine was not significantly different compared to placebo
I see.
with regards to our co-primary endpoint of 72 hours cumulative urine volume or change in cystatin C. But what we did note was that the patients that received low-dose dopamine, they were more likely to have study drug discontinued or dose reduced due to tachycardia.
I see.
And they were less likely to have study drug discontinued due to hypotension. So coming back to the point that Maggie was trying to make early, so one of our conclusions is that this renal dose dopamine is actually not renal specific because we saw systemic effects actually.
Okay.
Right.
And one last point to make was, although the ROSE study was not powered to look at subgroups, we did have pre-specified subgroup analysis, and there was a suggestion of differential response in patients with preserved EF versus reduced EF.
Sure.
Yep.
Very interesting. Nesiritide, likewise,
Yes.
results briefly.
I think they really mirrored what we found with dopamine in that when added to an aggressive diuretic program, low-dose nesiritide did not enhance decongestion or favorably affect renal function. And there was, again, this differential response where it was suggested that in patients who had a low EF or a low blood pressure, there was a trend towards benefit, where not in patients with a normal ejection fraction. So we know vasodilators can have a very favorable effect on the physiology of a patient with systolic heart failure. So, you know, I think this was an important finding. And the other thing we saw is that while we were targeting the kidney, hoping this was renal dose nesiritide, we still had a pretty significant incidence of hypotension with the low dose nesiritide, about 10%.
Okay. In the interest of time, I want to ask a couple of final questions. First one to you, Dr. Chen. With the neutral results of the ROSE study, should we be using dopamine and nesiritide at all in heart failure?
Right. I think as we were pointing out earlier, you know, the ROSE study would say that you should not use it routinely or prophylactically to prevent worsening renal function or to enhance renal function.
Sure.
However, you know, I think in patients we need to individualize therapies, and depending on what their circumstances and conditions, I think clinically there still is a role for low-dose dopamine or nesiritide actually. Yep.
Right. If you have a patient who has a reduced EF or very poor RV function, you've been aggressive with your diuretics, they're diuretic resistant, then that's the patient you need to move to the next step, which would be an inotrope, and you could use dopamine.
As the inotrope.
Yeah.
Okay.
And there may be select patients, similarly, where you think an IV vasodilator would be appropriate after stepped diuretic therapy has failed. Then that's the time to consider use of a low dose of nesiritide as a vasodilator, but not treating everybody up front.
Correct. And a final question, very brief summary. What did we learn from the ROSE study that we can apply to future clinical trials in heart failure?
Yeah, I think one of the takeaways that we learned from a ROSE study is that, you know, as we proceed with future studies in acute heart failure, you know, which is such a broad diagnosis and includes such a diverse group of patients, that we should start designing studies to target subsets of the patients with acute heart failure, such as those with preserved EF, those with reduced EF, or we could go with those with elevated blood pressure and those with, you know, low blood pressure. So I think we need to be more specific in our target population.
Right. I agree. I think that's the take home from this trial.
Well, thank you. And obviously a very tough and continuing problem for our patients, but we'd like to do the best for them. And thank you for participating in the study and in this heart.org video presentation today. Thank you very much.
Thanks, Eddie.
Thanks, Eddie.
Welcome.